Hello. So my name is Dr. Sriniketh Sundar. I'm an interventional pain management physician with OrthoVirginia. Specifically, I'm located in our northern region, in our Ashburn and Reston offices, but we have offices throughout the entire state. And we're going to just talk about some advanced modalities we have to help treat patients' painful conditions today. So just like this slide dictates, we'll go over some advanced modalities in pain management. This is just a general overview. This is not like a in-depth topic about any one topic. So every time we see a patient, we go through a whole list of treatment options, right? This is after the workup is done and we come up with a plan. So from the least conservative, from lifestyle changes, activity modifications, how we go about our day-to-day, sometimes strengthening with physical therapy. A lot of our bread and butter with what we do are injections, which is a whole different topic in and of itself. Sometimes surgery is the right answer, or patients have already had surgery. And luckily in our practice here, we work with physicians and surgeons from many different orthopedic surgical specialties. But let's say we're kind of in that in-between stage. Maybe surgery is not the answer, it's already been done. All the other conservative measures or injections have already been done. We could go over other modalities, such as the ones listed here today, and we'll just jump right into it. Next slide. So the first thing we'll talk about is radiofrequency ablation. We'll call it RFA for short. Ablation in the term is essentially just used to alter, or for lack of better words, destroy, right? So it could use heat, cold, sometimes laser technology, or in our case, radio waves or radiofrequency as modalities to treat these tissue. So in our purposes, we use radio waves to generate heat, or use short bursts of energy to alter the way the nerves function and send signals. Because ultimately, if the nerve is what's causing a painful signal to be sent to that part of the body, our goal is to stop that signal or change the way it's firing altogether. So where are the areas where we as pain physicians typically target with RFA? It could be in the neck for arthritis of the neck, in the low back for arthritis of the low back, and sometimes I do it even for nerve pain. Could be somewhere in the arm, the knee, the foot or the ankle, or even the shoulder. Just really depends on what our target is. Now, when I say nerve pain, some people think, well, can we do an ablation for pain coming from a larger nerve, such as the big nerves coming from the spine? Unfortunately, no. In my experience, that's not an indication, because those nerves carry way more signals than just a pain signal, that we wouldn't want to do an RFA on those nerves. Next slide. So then what are the different techniques in which an interventional pain physician can do an RFA? One of the more common is thermal, or creating heat. And this is I often use this in the neck or the low back. The thought process is you create a heat, you create a small scar where that nerve is normally living. And if you create a scar, that nerve isn't sending that painful signal to those arthritic joints of the neck or the low back, causing this pain. Another modality is pulsed. This uses short bursts of energy, kind of just then tapping on the nerve with these energy bursts to alter the way the nerve sends that signal, right? So even though we're not creating like a thermal scar, the thought process is gently tap on a nerve, change the way the nerve is firing, because a nerve is nothing more than just a channel with sending electrical signals towards a part of the body. Now, which one is best, thermal or pulsed? One thing we didn't mention here, because I don't believe many of us offer in our practice, is also cooled ablation too, using cold versus heat. But really depends on the doctor you talk to, right? So like I said, thermal I use in the neck and the low back, but maybe not for other nerves of the body, but another physician may be very comfortable doing that. It just really depends on, practitioner to practitioner and their expertise and their experience. Next slide. And well, how is it done, right? Most commonly, we're using X-ray or what we call fluoroscopy guidance to get down to the area where these nerves lie. But sometimes if it's a very specific nerve somewhere around the knee or the foot, we use ultrasound. But the real goal is to use some sort of image guidance, so we know where the nerves are, we know we're doing everything correctly and safely. And it's not as simple needle that goes in. It's a very specialized needle that is able to generate the heat, and there's a probe that goes inside the needle, and that's attached to a machine. So essentially a closed circuit between the patient to a machine to send the appropriate signal. Next slide. So this is just an illustration of a RFA procedure being done in the low back. On the left side of the screen on the upper top, you see a needle being directed towards a teeny tiny nerve just along that junction there. And that's that small area we're trying to target. The image on the right side of the screen shows those needles being directed towards those areas in a larger picture. And on the lower part of the screen, we see a machine. We don't see everything directly connected, but that's the process. We have the needles in, these wires are probes that connect to the machine, and the machine sends the signal to the needle to get the procedure done. Next slide. And this is just another illustration of what it looks like in an illustration standpoint. So on the right side of the screen, you see these needles coming into the junction of the low back, and that white halo effect is essentially illustrating the lesion being created, right? So if we're able to target that nerve, create a lesion, it's not going to send the painful signal to that facet joint that's also described in this image here. Next slide. So that's a brief overview of RFA, or radiofrequency ablation. Next, we'll talk about another advanced modality called spinal cord stimulation, or SCS for short. Another common term to describe this is also called neuromodulation. Essentially changing the way the nerve signals are perceived or sent, and that can change how we perceive pain. So how does this all work, right? It's a use of low levels of electricity to target the nerves. When I talk to patients about it, I describe it as a pacemaker of the spine. So the same way we have a battery attached to some wires to alter how the heart can fire and how it can, alter the signals. It's the same concept we're using but in the spine, right? So how does it work? It's delivered via what we call leads or insulated wires, and they go into what's called the epidural space. Now, the epidural is just an anatomical location within the spine itself, and you could put medication in there, you could put these wires in there. What we do with that space is it's what's most important. And like it says here, it's an outer layer of the spinal cord, so we're not penetrating through the entire layers of the cord. We just want to be in that small outer layer where we do a lot of our work. And this is a very common area that we target. What is commonly known as epidural steroid injection. It's a very common bread and butter procedure we do in the interventional pain world. And instead of injecting medication, the main difference now is to get an insulated wire or lead into that space. So the concept is to disturb, alter, or block that pain signal and the pathway between the spinal nerves and the brain. Now, when patients ask me, well, does this fix that nerve impingement, or does it fix the arthritis, or does it fix, the underlying cause? It's important to realize that what we're doing here is treating the pain. So if there is truly something that can be fixed surgically or other ways, then that's why it's an important discussion to have between you, the patient, myself, and a surgeon within that appropriate specialty to determine, is this the next right path for us? Next slide. So when is it appropriate? This is not a first-line treatment by any means. We always want to exhaust everything under what we call a conservative umbrella before we would even consider, at least in my opinion, neuromodulation or stimulation. So conservative measures can be the physical therapy, the medications, the more minimally invasive injections, and sometimes surgery is not necessarily indicated based on the patient's medical conditions or the underlying cause of the pain. And other times, surgery has already been done, right? Many times we see patients who've had neck surgery, low back surgery, maybe other surgeries throughout the body, knee, foot, or ankle. And if, in discussion with the surgeon, no more surgery is necessarily warranted, then maybe spinal cord stimulation could be a viable option for us to consider. What's the goal here, right? So I've already mentioned that while it 100% can target the pain, it doesn't target the underlying cause. So in our efforts to target the pain, we want at least 50% reduction in our pain. So if we could alter the painful signal and then modulate them, hence the term neuromodulation, then we could decrease pain and then little by little improve your function so that we could go about our day-to-day with less pain and overall have a better quality of life. Next slide. So what are the indications, right? First and foremost, not every patient is a candidate, and sometimes while someone may look like a good candidate on paper, it's very important to understand that, as I mentioned, maybe 50% reduction in pain is the goal. It may not be, the reality for everyone, right? Which is why it's very important to have the discussion. Now, most commonly, we do this for patients who've already had surgery, and maybe surgery is no longer indicated. So that's what we call post-laminectomy syndrome. Essentially, if there's the back or has been operated on and we've tried, exhausted everything else, then we could talk about this as an option. Now, this has been around for decades. It's not a new technology by any means, and the indications have expanded over the years. Chronic low back pain, what we call radiculopathy, or pain stemming from those bigger nerves of the spine itself. It has been done in the past for pelvic pain, a very nuanced topic of complex regional pain syndrome, which could be a very specific type of pain, most commonly in the feet or the hands, but we've seen it in the shoulder or the knees. And even diabetic neuropathy, right? Even though diabetes sometimes can be well controlled, sometimes that nerve damage is very difficult to treat with medications and therapy alone, where neuromodulation for the right patient can be quite helpful. Next slide. And so this is just an illustration showing how the system would work. On the right side of the screen, we have what we call a lateral view, which shows the wires going into the epidural space. And on the left side of the screen, just kind of a front-on view shows the wires coming in, and then right along the right side of the body, there's a small battery pack that's inserted to send those signals to the spine itself. Next slide. And just like everything, there's always a process involved. And the most common question I get is, how will we know if it works, right? I don't know how it'll work. That's why we have something that was called a trial, or kind of like a test drive, right? This is done to see, is the patient going to even benefit from spinal cord stimulation or neuromodulation in general? So the trial is a temporary procedure or temporary use of the wires, where we get the wires into that epidural space and everything is taped or is externalized to the body. So nothing is implanted, nothing is permanent at this stage. We keep it roughly for 5 to 10 days, and we check in with you every single day to see how's your pain, how's your functional level, how's your sleep, are you noticing a change, or is it not making a big difference at all? And that's the beauty of this, right? We're purely testing it to see, does it work? And then we typically will see patients back somewhere within that 5 to 10 day range. And if the patient says, this was amazing, then the next step is to consider the implant, right? So we take out the old wires and we wait to get to the operating room for an implant. Now, it could be done by a pain physician or it could be done by a surgeon, but this is a minimally invasive outpatient procedure. It takes anywhere from 45 minutes to an hour-ish or so. And now, instead of taping it to the back, everything is now internalized and then it stays with you. Next slide. And this is just a actual X-ray of what it would look like. And so at the top of this image, we see what's labeled as electrodes. These are the really thin wires that are sitting in the epidural space. And as we track those down, we see what's labeled as an IPG, which is that small battery or pulse generator, which is implanted in. Next slide. Patients always ask, well, can I turn it up? Can I turn it down? Can I turn it off? Naturally, one recipe is not going to, solve everyone's problem. So there's a lot of different programs available. And day to day, weather changes, our lifestyle changes, activity level, our pain level may vary as well. So patients will have different programs available to them. So they're not just stuck with one and done type ordeal. The people from the companies will here to work with you to make sure we get the right programming for the right patient. A lot of these devices are now MRI conditional or compatible. There's different degrees of MRI, 1.5 Tesla or 3 Tesla. To my knowledge, many of these are 1.5 Tesla compatible at least. And in due time, I'm sure many of them will keep on expanding their abilities. Now, let's say for any reason it needs to be removed. Let's say the system fails or something happens or patient just wants it removed for whatever reason. Sometimes patients have surgeries that need it removed. It can be reversed if needed. But ideally, we try to maximize the benefit of the therapy before it comes down to that. Next slide. So we talked about spinal cord stimulation. So next we're going to talk about peripheral nerve stimulation. The main difference between this and SCS is instead of getting into the spine itself, we're trying to target different areas of the body around, or what's called the periphery. So most commonly, this could be done for chronic shoulder pain, arm or hand, hip, knee, and the foot or the ankle. Similar concept, use a low level of electricity to target the painful area, right? Now, similar to spinal cord stimulation, this is not limited to patients who have already had surgery, because not all conditions can be treated surgically. But I personally have seen patients who have already had surgery for which peripheral nerve stimulation has been beneficial. Next slide. As we saw with spinal cord stimulation, ultimately, once the trial is done, the battery and the generator and the wires are all internalized. It's a little bit different with peripheral nerve stimulation. So a lot of systems do have a small little battery that gets inserted, but typically there's also what we call a wearable piece, something on the outside of the body to make the whole system work and to close that circuit. And the advantage of this is you could use it as an as-needed basis. So you don't have to have a battery inserted the entirety of the time. When a patient needs it, they could attach this wearable, turn it on, and go about their day. MRI compatibility may vary. Again, it depends on the system, depends on where it's implanted, but CT scans are still doable, X-rays are still doable, so that's okay. And similar to a spinal cord stimulator system, we should always try to do a trial first. Because what if it doesn't work for you, right? Then we wouldn't implant. That's why we always want to do a trial, make sure it works for you, make sure it's targeting the painful area. And if it really works and if, everything, get all our ducks in a row, then we would move forward with an implantation. And just like RFA and just like spinal cord stimulation, some sort of image guidance is often used to find the right nerve, typically ultrasound, but there are some nerves that get targeted with X-ray as well. Next slide. So this is a diagram showing a very particular system. On the bottom of the screen, with those arrows you see that little wire targeting the end of that nerve, and then that sticks into the skin itself. And on top of the skin surface, where it says external transmitter, that's that wearable piece where it's an adhesive that's attached to the skin to target that nerve as needed. And this is a little older image, but now with advent of technology, you don't even need this type of remote. There's more advanced devices now to turn it on, to turn it off, to play with the programming in the system. Next slide. And this is just another diagram of what it may look like. So here we have a stimulator lead targeting patients who have chronic shoulder pain, for example. So at the lower right end of the screen, we see these dashed marks. Those are the electrodes itself to target the nerve. And then we could see that this wire is ultimately inserted under the skin and to treat the nerve pain. Next slide. And just another diagram, like I said, there's many different companies out there. This nerve stimulator device is showing what it could look like for knee pain. So around that blue, we see the ends of the wires to target those nerves. And as we track that up, a little device that sits underneath the skin. And on the right side of the screen, that circular white disc, that's the wearable for this company to target that pain. Next slide. Now we've gone over RFA, different forms of modulation or stimulation. We'll go on to something a little bit different called kyphoplasty or vertebroplasty. Now, we're kind of changing gear here from chronic nerve pain or low back pain or neck pain to typically something we do for more acute patients. So this is a minimally invasive procedure to treat what we call vertebral compression fractures. The entire goal is to fill that fractured segment with cement. They take up those nooks and crannies of that fracture to decrease pain, decrease the swelling, and to allow healing to occur a bit faster. It's an outpatient procedure, typically done with just 1 to 2 small incisions for a single level. And oftentimes, again, we don't just jump to this procedure right away. When I counsel a patient on this particular procedure, we say, well, let's try conservative measures first. So that could be giving it time, seeing if time alone will help heal it, using bracing such as back braces or braces to target the area where the pain is, pain medications, activity modifications like avoiding heavy lifting, maybe we have to change how we move for a little bit. And if all that fails and the pain still persists and someone's functional status is significantly limited, then we could talk about this procedure. Now, do all fractures need to be treated? Absolutely not. There's many fractures I see we treat it very conservatively, and sometimes a fracture may be just not safe to do the procedure on. So that's why I go over the imaging, talk about everything with the patient before we move forward. Next slide. And this is just a diagram of what a fracture can look like. And so as you can see, this bone compared to the one above it and below it is compressed. So hence the term compression fracture. And this is just an X-ray image of what a compression fracture may look like. So in the middle of the screen here, on top and on the bottom, we see nice squares. Those are unfractured segments, but right in the middle, it looks like it's a wedge. So we call it anterior wedge compression fracture. Next slide. And this is a simple diagram. This is clearly an oversimplification, but it gets the point across. Starting from left to right, we have a needle that enters that fractured segment. We inflate a balloon to create a cavity or create a space. we take out that balloon, and then the goal is to fill that void with cement to help, if we're lucky, get some height restoration. But really the primary goal is to provide stability and balance back to the spine. Next slide. And just some sample images of what it may look like after procedure is done. And so we see here on the frontal view and what we call lateral view, that bright white is that cement now taking place of a lot of that fracture segment. Next slide. And this is just a brief overview of what the more common advanced modalities are, but by no means is it an exhaustive list. There are other procedures listed here, such as decompression, muscular stimulation, different fusions, pumps, and ablation. The efficacy, the validity of these is all different points to discuss. I personally don't do these currently, but there may be a lot of other physicians out there that do this. But I just wanted to let you folks out there know that what I've discussed so far very briefly are not the only advanced modalities out there. Next slide. And that's all I have for you. So I think we'll just open it up to some questions.
Thank you so much. We will be answering questions submitted earlier and questions submitted live. Not all questions will be able to be answered, but we'll get through what we can. Our first question is, what types of tests are needed before you choose a treatment? Do people do x-rays, CT scans, MRIs, ultrasounds?
So typically, almost always, we always will get x-rays just to make sure there's no bony issue that may need to be addressed. CT scan, MRI, it's very common for us to get those because by the time we get to a lot of these advanced modalities, all this workup has been done, right? So it's not uncommon for a lot of our patients to have had MRIs, x-rays done. Ultrasound, if it's diagnostic for diagnostic purposes, sometimes we could use an ultrasound to see, but very, very rarely do I know of anyone that will just jump to these without a full workup being done first.
Thank you. How long is recovery after any of these procedures?
Fortunately, with a lot of these being very minimally invasive, recovery is not that long. For an RFA, for example, it's small needle puncture, so there's really no recovery, I would say. For spinal cord stimulation or peripheral nerve stimulation, those are slightly more advanced procedures with small incisions. So recovery, you may have some incisional soreness for a few days, but we're not talking weeks or months of recovery. You might have some pain for a few days, but that will decrease little by little. Then even for a kyphoplasty, it's just small incisions, right? So recovery is not terribly long. Now, to heal fully from certain things, obviously with time and physical therapy, that's a different issue, but procedural recovery itself is not that long, a few days max, typically in my experience.
Thank you. Are there upper or lower age limits for treatment?
Not necessarily. It all comes down to discussion, right? I've treated very functional 90-year-olds who, they live on their own, they're still very active, they're traveling. And then sometimes you just, due to other medical conditions, you could be a lot younger and a patient may not be a good candidate for this, right? So age is just one factor we determine in how we treat and who we treat, but ultimately it comes down to other medical conditions, other medications someone might be on, other lifestyle changes and things like that. So age itself is just a number. It's a factor for sure, but it doesn't define, there's no hard stop on upper or lower.
Thank you. Are these procedures usually covered by insurance?
Great question. So the unfortunate answer is all depends on the insurance, right? And it all depends on the procedure. So even what bread and butter stuff that we do on a daily basis, sometimes we have challenges with your insurance company, right? And I'm very honest when I talk to a patient that while someone may be a good candidate, I cannot guarantee insurance will cover it. So obviously we would only move forward if we get the insurance approval. And little by little, I feel like things are changing. We're getting better coverage as we go. So not all insurance companies will cover all procedures. And in the event it doesn't, we have systems in play to try to get around those, what we call peer-to-peers or appeals, which is a whole different discussion. But we would never do something for you if we know insurance is going to deny it.
Thank you. Do you need to do physical therapy after any of these procedures?
Need is a maybe not need, but oftentimes I do recommend it, because that allows, if you could reduce the pain, then the hope is that allows you to be more engaged in exercise or physical therapy. Now, sometimes patients have already done PT and they're very comfortable with the home exercise program, but many other times, if pain has been limiting you for so long, it can't hurt to just get re-engaged into a therapy course to relearn exercises and figure out how we can continue to strengthen.
Thank you. Is there a limit to the number of injections you can have? And when do you switch from injections to procedures like these?
So I think the limit's really based on the type of injection. And, commonplace what we say is every 3 to 4 months for different types of injections, especially when we're talking about steroid. Sometimes we need to wait 6 months or 12 months based on the procedure that we're doing. So there is a limit, but there are some people who could get these done, twice a year for the rest of their life for the bread and butter injections, and it's fine. When do we switch? It depends on the patient's pain level, right, and functional level. If they're overall functional and they're continuing to have good pain relief with more conservative or minimally invasive approaches, then why switch, right? The discussion really comes if things are just progressing or they're not getting as much pain relief as they were hoping for.
If someone has back pain as well as knee or hip pain, is there a set order to be treated in?
So there's no order necessarily. Many, many times, unfortunately, everything is connected back to the hip, hips to the knees, knees to the feet. So it really becomes a discussion of what's worse. And there's times where we may treat the low back and it's okay. Then we come down to the knees or hips, get misaligned or have pain. So it's not an algorithm where we say we start with the back, then the hips, then the knees. Just a matter of looking at the imaging, looking at your symptoms, and trying to figure out what's the best way to start.
Thank you. Are the procedures themselves painful? Is there any sort of anesthesia used? What's the pain relief on that part?
So for almost all procedures, we will always use lidocaine or an injectable numbing agent to decrease the discomfort of the procedure. Very common question I get in for our bread and butter procedures. Every patient is different. We've done more advanced modalities on patients who are awake because that was their choice and everything went well. But for a lot of these procedures, it's, just lidocaine, maybe mild oral sedative, or you could be done under mild, moderate sedation. Often these do not require a full general anesthetic. Now, let's say you are getting something implanted, then the topic of the deeper anesthesia comes into play. But for a lot of these, usually just oral sedatives and numbing agent, or, if needed, some moderate sedation does the trick.
Thank you so much. That is all the time that we have for today. Dr. Sundar, would you like to close?
Sure. Thank you so much for joining today. Hopefully you have a better understanding, at least a brief overview of some of the advanced treatments out there. And, I think through collaboration with us or your physician, we could come up with a plan for you.